Morning, everyone. So I came running in here at like 7:30 this morning because I was afraid I was going to be late for an 8 o'clock meeting. And there were already people here. And I'm so excited that everyone here was here bright and early. And most importantly, our good friends from Panera were here with like trays and trays of good food, which is always a happy way to start the day. Um, my name is Susan Alvarez. I am the Director of Environment and Development here at the North Central Texas Council of Governments. Shameless plug, if you are not familiar with our agency or what we do, we are the designated metropolitan planning organization for the 16 county area, otherwise known as DFW. And so we do a lot of coordination. Our whole thing is coordination, collaboration, communication, blah, 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 all the C's. So I am very excited to welcome you this morning to the 2025 North Texas Asthma Summit. Before we begin, we've had some, and I hate to tell you this because we're in a glass building, but we've had some credible threats, not on this meeting, but for some of our other topics. And so we now have pre-meeting housekeeping that includes safety. So per our internal requirements, to ensure that everybody has a safe and comfortable meeting, key things to note: there are building maps near every door so you can see where the entrances and exits are. We do have storm rooms. As you might guess, it's the bathrooms on the interior walls of the building. The restrooms are located in the center of the building. Unfortunately, we are in the middle of getting some foundation repairs to the building done because you may see it along some of the sidewalls, we have some foundation issues. In the process of doing that, they discovered some plumbing issues. And so while they fixed the men's room, they are now currently literally digging up the women's room to get to the plumbing and fix that. So I apologize. Find a marked restroom of the gender you prefer. I think we're good, but if there are issues, let me know. I can badge you up to one of the other floors for the facilities there. In case of fire or violent act of threat, we'll go out the doors marked exit. If we're not able to leave the building, one of the things you may notice is by the doors, there's some weird, funky red things. Those are for barring the doors in case of active threat. The other thing that I will tell you is in case of a medical emergency, we have an AED unit in the reception area where you came in. There are also stop the bleed kits there. I hope we don't need them. If you have challenges, please let me know. There are, related to the conferences, all kinds of great community information on the back and side tables. Please visit and get appropriate information that you don't otherwise know. We do have snackage in the back, and we're excited about that. Be mindful of the microphones in front of you. If you want to talk, if you click the little the little face graphic on the microphone, it'll turn the microphone on and there'll be a red light to show that you're live. Don't say horrible things while you're live. And then turn it back off, because otherwise there'll be all kinds of extraneous paper shuffling and stuff that will impact the folks that are online. The other thing is, I want to take a minute and thank our wonderful partners. Without you, none of this would be possible. And this is actually, I think, the second year we've done this. The whole thing is in the power of partnerships. That's one of my lessons learned, both at the city and here at the COG. We're off in our own little worlds doing our thing, but we have so much more power if we can connect with other people doing similar things. It's kind of like, I'm a hydrologist by study, and it's kind of like when you get a couple drops of water that run into another couple of drops of water, and all of a sudden you've got a river that can scour out a valley. And so the same thing goes with social action. And so I'm really excited to see everyone here today at COG and also all our online partners. Happy that you are here. With that, I think I'm going to go back to the main slides if I can. Yes. I'll get rid of this as well. So, to officially welcome you to Summit, I would like to introduce you to Dr. Leslie Alsop. She is the Asthma 411 faculty partner and kind of one of the instigators behind hosting this partnership today.
Thank you so much, Susan. And thank you to everyone. I could not be more delighted to welcome everyone here today for our second annual North Central Texas Asthma Summit and to celebrate our shared commitment to improving asthma outcomes for children and families across our region. It was just 1 year ago that we convened our first annual asthma summit that had been held for our region in over a decade. And that event laid a foundation for us for something bigger, a sustainable coalition to reduce the burden of poorly managed asthma on our children, our families, and our communities. Since then, our tremendous thanks to the partner organizations that were listed on the slide and in the program materials that have come together and to begin building that coalition. Over the past year, we have focused on defining a clear, shared vision that's grounded on the needs of our region and guided by a commitment to collective action. So the problem statement that you'll see there on the slide is where we began. The burden of asthma in North Central Texas is too high. We have fantastic resources, medical resources and others, and yet too many children struggle to breathe as they go through the pathways that children need to go through school, through their activities, and have that hanging over their head and of their families. How are we going to get through this day? And will we be able to breathe throughout it? And it is disproportionately borne by those children and families who are already facing other burdens and obstacles to reaching their full potential. Our purpose, we'll go from there, to improve asthma outcomes for all children in our region, building partnerships that address these cross-sector drivers of adverse outcomes. None of us, as committed and talented as the different organizations and partners are that are represented here today, can solve this problem unless we work together and reach across sectors. Improve coordination, which we have to do to make these services that we work so hard to develop actually serve our children and families and find the gaps. Let's go forward. We've identified 17 counties, the 16 counties of the North Central Texas Council of Governments, this region that Susan mentioned, and Grayson County as well. And we invite all of those who are within those 17 counties and who serve those 17 counties to come together in this commitment to improve asthma outcomes and to help our children breathe with ease through their day. Next slide. We are also have chosen the commitment to collective impact framework. It's an evidence-based approach to bring diverse partners together to achieve our common agenda with shared measurements and aligned efforts. So we invite those organizations and individuals from across our region to join us in this vital work. Your ideas and your voices and your leadership are all central to reaching this goal that we all share. Thank you. And with that, please join me in welcoming our keynote speaker, Dr. Darlene Bhavnani. Dr. Bhavnani earned her doctorate in epidemiology and her master's of public health at the University of Michigan. She worked in public health practice and global health for nearly 10 years before beginning her academic career as an assistant professor at Dell Medical School at the University of Texas at Austin. Her research focuses on social and environmental determinants of upper respiratory viral infections in children with asthma, with a hope that the results inform sustainable public health interventions to reduce the burden of asthma exacerbations. Thank you so much, Dr. Bhavnani.
Thank you for having me. It's an honor to be speaking with you all today. As my slides pull up, I just want to say that I have no conflicts of interest or financial disclosures. And I also want to mention that I am not a physician who treats children with asthma. Instead, I'm an epidemiologist, and my focus is really on conducting population level studies in order to help inform the design of interventions that may then help to prevent asthma morbidity among children with asthma. So I hope you all can see my slides.
Yes, we can see them.
Great. Okay, thank you. So it's with that lens of preventing poor asthma outcomes among children with asthma that I speak to you today about neighborhoods, homes, and respiratory health. So we're all here today because we want to see improved outcomes in children with asthma. So I thought I'd start us off with this map of emergency department visits in children living in the Dallas-Fort Worth area. So what you're looking at here are essentially counts of these asthma-related ED visits divided by the population in each census tract in the Dallas-Fort Worth area. And the reason we're looking at counts divided by population estimates, or essentially rates, is because that allows us to make comparisons across tracts and across time and populations. So what you'll notice here is that there are lighter colors and darker colors, and the darker colors indicate much higher rates. And so I hope you'll see that there's just a lot of variability by neighborhood in asthma-related ED visits. Now moving to Austin, Texas, which is what I'm more familiar with, we see a similar pattern that these asthma-related emergency department visits in kids really vary by neighborhood. But, and I hope my pointer will work here. And what you'll notice too is that this black line that I've indicated that cuts across each map is the I-35. So this cuts across Austin. And it's really east of Austin where we see really high rates, especially in the non-Hispanic white children and our Hispanic Latinx population. So I think you'll also notice, it's very obvious, that there are racial and ethnic disparities here. We see much higher rates of these asthma-related emergency department visits in the non-Hispanic Black population, and to some extent in the Hispanic Latinx kids compared to our white children. So I think these observations raise two very important questions about asthma exacerbations in these metro areas. And the first is, why are asthma exacerbation rates different by neighborhood? And the second is, why are these rates so different by race and ethnicity? Now, when I talk to my colleagues here in Austin about it, they're just like, yeah, okay, it's socioeconomic status and it's lack of healthcare access, okay? But even when investigators actually account for these factors in their studies, we still see that racial and ethnic disparities persist. Sorry, I'm not able to advance my slides very well. Okay, so what I want to say is, in thinking more about these racial and ethnic disparities in asthma exacerbations, I want to point out that there really are a number of different triggers of asthma exacerbations. And we've been focusing for decades on the entire range of triggers and thinking about asthma exacerbations very broadly. But the vast majority of asthma exacerbations are triggered by upper respiratory viral infections. And actually, some studies suggest that this may be up to 80 to 85% of asthma exacerbations are triggered by these viruses. So maybe the question that we should be asking is what leads to upper respiratory viral infections in children with asthma, since that may be a precursor to asthma exacerbations. And then naturally, an extension of that is, the question about whether differences in viral infections could help to explain differences in the risk of asthma exacerbations. So to look at this and to examine the effects of respiratory viruses, we actually leveraged patterns that we saw during the COVID-19 epidemic. So during the first initial days of the pandemic, we were all, instigating, or we were all implementing community-wide prevention measures, right? Things like staying at home, working from home, keeping our kids home from school, masking, anything that we could do to prevent transmission of COVID-19. And the secondary effects of those actions were that there was this overall reduced circulation of upper respiratory viral infections in our communities. And as a result, in communities here and abroad, there were dramatic reductions in asthma exacerbations, and these asthma-related emergency department visits actually declined. So the question that we were after is whether these declines in asthma-related emergency department visits were equal for Black, Latinx, and white children. Because if they weren't equal, that might suggest that upper respiratory viruses affected one group more than another. So we used data from the Dell Children's Medical Center, which is our local hospital for children here in Travis County. And it was the only hospital at the time in Central Texas for kids with an emergency department. And we took asthma-related emergency department visit rates from before, during, and after these community-wide COVID-19 prevention efforts. And again, we calculated these population-based incidence rates that I talked about earlier among school-aged children, and we compared rates by race, ethnicity, year, and season. And so what you'll see here in 2019, in the spring, so this is 1 year before COVID really hit, Black children had nearly a 7-fold higher rate of asthma-related ED visits than white children. So on the y-axis of the plot, you're seeing the rate ratio. So that's 7. Now, during COVID-19 mitigation efforts, again, when there was an overall reduction in upper respiratory viral infection in our communities, this ratio decreased to 2-fold. So disparities were dramatically reduced. And so this suggests that upper respiratory viral infections actually help to explain these racial and ethnic differences in asthma exacerbations. So at this point, we were thinking, oh boy, this is kind of a new hypothesis. What is known, what is already out there, what is known about racial and ethnic differences in upper respiratory viral infections, both in the general population of children and in children with asthma? So we went to the literature and we found pictures like this. Okay, so what you're looking at are hospitalization rates, which is on the y-axis, and I think they're showing over time. But what you'll notice is that the different curves represent different age groups, and the bolder curves represent Black children, the lighter curves show white children. And what you can see very, very clearly is that Black children are at increased risk of becoming hospitalized, and in this case, it's for influenza, regardless of the age group. So we saw these same patterns across the literature in other age groups, and for not just for flu, but for RSV. So these patterns, though, of increased hospitalization don't actually tell us whether there are differences in getting infected or whether there are differences in having a more severe infection that then requires hospitalization. So we were kind of scratching our heads at this point, and what we needed was really some source of data that could capture not just severe illness, but those milder infections that might not lead to somebody seeking care with their doctor or in hospital. So we turned to survey data. Now, there are nationally representative surveys out there in the United States, and we found one of them, the National Health and Nutrition Examination Survey. And we picked survey years 2007 to 2012 because during these years, children were invited into the survey, and there were also respiratory examinations that were conducted in these children. And during the respiratory exam, children and their caregivers were asked about common cold symptoms in the past 7 days. And importantly, these didn't include symptoms related to allergies or hay fever. What was also included in that respiratory exam were measures of lung function, so spirometry was conducted, and FeNO was measured. So that's the objective marker of eosinophilic inflammation. So we looked at the data, which indicated, answers to this question about common cold infections. And we looked at this by race and ethnicity. And what we found was that among those with asthma, Black and Mexican American children were actually twice as likely to report having an upper respiratory infection than white children. And what was interesting too was that among kids who were infected, Black and Mexican American kids were not any more likely than white children to have those lower respiratory symptoms. So what I mean by that is reduced lung function or higher levels of FeNO, eosinophilic inflammation. And so what this suggests is that Black and Mexican American children may be more likely to get infected, but may not be any more likely to have a more severe infection that then leads to an asthma exacerbation. So it's something about getting infected. So thinking about what Black and Mexican American children across the US have in common, well, we know that they're more likely to live in disadvantaged neighborhoods. So here I'm showing you data from 100 cities across the United States. And the marker of disadvantage here is the Child Opportunity Index that some of you may be familiar with. But generally, along the x-axis, you'll see that this marker of opportunity varies from very low to very high. And you'll notice that Black children, who are represented by the blue bars, and Hispanic kids, represented by the red bars, are overrepresented in the very low and low opportunity neighborhoods. So, thinking more about this, we wanted to know whether neighborhood disadvantage was associated with the risk of upper respiratory viral infections, and even more specifically, in children with asthma. So what we did was we took advantage of what is known in the literature as the September epidemic of asthma exacerbations. So these data come from Texas that I'm showing you here. And I'll say that typically there is an epidemic of asthma exacerbations when children go back to school. And in Texas, we see this epidemic start to take fold in mid-August. That's when our kids return to school here, peaks in about September, and then starts to fall later in September. So what we know about this back-to-school epidemic is that it is almost entirely driven by upper respiratory viral infections, because now kids are congregated in classrooms, and they're in indoor spaces, and they may not have immunity to circulating strains of these viruses. So these data are modeled from data from Dallas, and they show that the contribution of common cold infections to asthma exacerbations really peaks early in September compared to before school and at the end of the school year. So what we did is try to understand if this back to school epidemic actually differed by neighborhood disadvantage. So we took Texas healthcare information data. Now these are ED data that span the whole state of Texas, and it also includes hospitalizations. And we limited our data set to just 4 cities, so Houston, Dallas, Austin, and San Antonio. And again, we summarized those population-based ED visit rates by week and by census tract. And what we were interested in was using this back-to-school period as a proxy for viral-associated asthma exacerbations. And we used the back-to-school rise, or this increase in slope that you see, as a proxy for viral transmission, so that propagation of viral infections. And we evaluated whether neighborhood disadvantage influences viral-associated asthma exacerbations and whether it influences this transmission of upper respiratory viruses. So here I show you a different marker of neighborhood disadvantage, which is the Social Vulnerability Index. It generally incorporates themes related to socioeconomic disadvantage, but also racial and ethnic minority composition, housing type, and transportation. And what you'll see on this graph here is that we're showing rates of asthma-related ED visits on the y-axis and week relative to back to school on the x. And you'll notice that there are 3 different curves. So the blue curve represents those neighborhoods with high social vulnerability. Essentially, they're more vulnerable to external stressors. The green curve indicates moderate social vulnerability, and the red curve shows low social vulnerability. So what I think you'll notice is that relative to summer, the blue curve, those more disadvantaged neighborhoods, is much higher, peaks higher, and there's just higher overall difference in rates relative to summer, compared to the red curve, which is low social vulnerability. And what you'll also notice as well is if you look at that increase, that rise in the slope as children go back to school, as the curve crosses week 0, that slope is much higher in more socially vulnerable neighborhoods. And so we think this indicates greater viral-associated asthma exacerbation rates and increased viral transmission in those more disadvantaged neighborhoods. So at the same time, while conducting this type of work or engaging in this question, we tried to understand whether housing factors were important as well. So we went back to that survey data where we found that Black and Mexican American kids were more likely to report having an infection. And we tried to understand what kinds of housing factors help to explain that association that we were seeing. And we looked at various indicators of household poverty, and we noticed, yes, income poverty ratio really does matter. But what we found that was very interesting was that living in a rented home explained nearly 40% of the association between Black versus white race and having an upper respiratory infection in kids with asthma. So the literature supports this really tight link between home ownership and risk of respiratory infection. It was Sheldon Cohen in the 1990s, this great, investigator who performed these really landmark studies where he would invite adults into his study. He would conduct surveys or apply questionnaires, and then he would challenge these adults with common cold viruses, and then have them stay in a hotel for several days or up to a week while he monitored them for infection and cold symptoms. So these are very, very nicely designed experiments. And what he found in one of these studies was that those adults who reported that their parents owned homes for longer periods of their childhood were less likely to actually get infected upon viral challenge than those adults whose parents owned homes for fewer years. So there's something about home ownership that might increase the risk of infection. But what is it? Well, I have a few hypotheses that I want to run through with you. One could be something to do with our schools and what kids are facing at school. Maybe there's school presenteeism at play here. So what I mean by this is, let's look at some data. There's nationally representative survey data again that show that children living below the federal poverty level were actually 23% more likely to have a stomach illness, 5% more likely to have a cold, but 9% less likely to have missed a day of school in the past year, compared to children living above the federal poverty line. So what this tells me is that, okay, maybe these kids are getting sick more often, but they're not missing school. And could it be because their parents don't have sick leave? Could it be because of fear of loss, economic loss if parents stay home from work, or could it be something else? Well, children living in disadvantaged neighborhoods may be more exposed at schools. So it could also be that children are more exposed to viruses at schools because these schools are more crowded or poorly ventilated. It could also be that crowding and ventilation are seen at home in disadvantaged neighborhoods. And we do know that children living in disadvantage do live in more crowded spaces, and they tend to be poorly ventilated, which can then influence the amount of virus that they're seeing in the air. It could also be through exposure to air pollution. So we know that children living in disadvantaged neighborhoods are more exposed both to indoor and outdoor air pollution. In another viral challenge study, okay, this one's not done by the Sheldon Cohen's group, but it's very elegant as well. Adult volunteers were invited into this experiment, and they were exposed to either healthy air or diesel. And then they were challenged with upper respiratory virus. And what you'll see here on the y-axis is replication of the virus in the adult volunteer. And what you'll notice is that the group exposed to diesel had much more replication. So their immune system couldn't fend off the virus as well as those that were just exposed to air. And this pattern is seen regardless of whether the individual was allergic or not. So there's some really good data tying air pollution to viral infection. Okay, it could be through stress. We all know that when we get stressed out, we're at increased risk of getting a cold. Same thinking for children. And it's possible that children who live in disadvantaged neighborhoods may be more exposed to neighborhood stressors like violence, discrimination, physical disorder, and even a lack of social cohesion, which could impact immune function and susceptibility to infection. So going back to Cohen's studies with adult volunteers, during one of his experiments, he asked these volunteers about life stressors. And what you'll notice is that those who had reported no stressor were at decreased risk of having an infection with cold symptoms. And importantly, too, the duration of stressor seems to matter. So those who had stressors for longer periods were at increased risk of that infection with cold symptoms. Okay, finally, it might be through pest allergens. We know that indoor pest allergens are more commonly found in disadvantaged neighborhoods and in rented homes compared to owned homes. And just like air pollution, stress, allergen exposure could actually impair host viral defense mechanisms, so make somebody more susceptible to infection upon exposure. So we actually found in a sample of Black children from Baltimore that exposure to pest allergens was associated with having a symptomatic infection in kids with asthma. It was actually a doubling in cockroach allergen concentration actually increased the risk of having an infection with both upper and lower respiratory tract symptoms. And you'll see that as the symptoms become worse, the strength of the association also increases, so that odds ratio is moving. And results were similar for air mouse allergen. So there may be some risk here associated with this pest allergen exposure as well. So I want to introduce TexHale, which is called the Texas Home Assessment of Asthma and Lung Exposure Study. And it's designed by my mentor, Dr. Elizabeth Matsui, in order to evaluate the effects of these environmental exposures in children with asthma on different outcomes. So these are phenotype, asthma morbidity, and lung function growth. So what my mentor, Dr. Matsui, is doing is she's recruiting children from different neighborhoods in Central Texas across the range of poverty or disadvantage. And her and her study team are going into homes and actually taking measurements on these exposures and then following children for asthma outcomes over time. And what's nice about this study too is that there's a large representation of Black and Mexican American children. So using TexHale, we can actually study viral associated asthma exacerbations as well by adding on nasal sampling of in children's noses to look for viral infection. And some of the measures that we're actually interested in are of crowding. So here we're thinking about area per person or bedrooms per person. We're trying to look at ventilation. So we're measuring CO2 concentration as a marker of ventilation in individuals' homes. We are measuring PM 2.5 and PM 10 NO2 concentrations indoors, but we're also capturing outdoor or neighborhood level air pollution as well. And we're surveying parents and guardians about those neighborhood stressors that I talked about, like neighborhood violence, social cohesion, and discrimination, as well as others. And importantly, the team is going in and vacuuming up dust in order to be able to understand what concentrations of allergens may be found in that dust. So the reason we want to look at these outcomes, like viral associated asthma exacerbations and environmental factors, is so that we may be able to inform the design of interventions. So if crowding, ventilation, and air pollution were deemed to be very important, if our data supported that, we might think about installing air filters in homes and schools. I mean, some of you may be more of an expert on these, but as I understand it, HEPA filters can reduce exposure to airborne viral particles by up to 65%. And there's this added bonus too of being able to reduce PM 2.5 concentrations, which has a separate pathway, not through viruses, to asthma. If neighborhood stressors instead were important, we might think about moving to opportunity neighborhoods. So taking those children who are at highest risk and moving them from one neighborhood to another, which has been shown to cut asthma symptoms essentially in half. Or we might think about place-based interventions. So neighborhood level interventions like remediation of vacant lots or green spaces, upgrading parks, maybe investing in youth programs to improve social cohesion. For pest allergens, if we found that pest allergen was important, we might think about pest control or home reparations. So there are a number of different interventions that might be applied to different types of exposures. So I want to say here that local organizations and community members will absolutely play a key role in intervention design and testing. It wouldn't be possible without you all. So if we were thinking about air filters in schools, we might partner with local public health and independent school districts. If instead we were thinking about air filters in homes, we might engage with community health workers or even local housing advocacy groups, as well as safety net providers of asthma care in order to help recruit patients into a trial and spread the word about this intervention. So while we don't know what exactly leads to a higher risk of respiratory viral infection among disadvantaged populations, we do have enough of a sense of those environmental factors that cause exacerbations and likely also contribute to the increased risk of infections. So we can make some recommendations, and you'll see here I include different recommendations related to pest, mold exposure, dust mites, air pollution, and tobacco smoke. But just as two examples, say we were after reducing exposure to pests and pest allergens, we might connect families with healthy housing advocacy groups or even services. If instead we wanted to target or eliminate tobacco smoke exposure, we might do this through advocacy or policy about home smoking bans. So to summarize, I just want to say and leave you with this message that we see large racial and ethnic disparities in respiratory viral infections in children with asthma, and may contribute to the disparities that we find in asthma exacerbations. And our work, as well as that conducted by others, really demonstrates a strong link between markers of disadvantage and the risk of viral infections in kids with asthma. I think our ongoing studies will help to provide insight into the specific types or buckets of exposures that increase risk of infection. And I would say that the results from these studies are really I'm hopeful that they will lend insight into the development or design and testing of interventions to reduce asthma morbidity in those most disadvantaged populations. So I'd like to acknowledge mentorship from Dr. Matsui and Dr. Rathouse, and say that this work wouldn't be possible without the collaboration of my study team and other partners, as well as my sponsors. I'm happy to take any questions.
This was absolutely amazing. Thank you so much. And that detailed information this is Sade, by the way, Afolabi, and that detailed information you were able to give us specifically about Dallas was really, really great. I actually, in my personal practice, have seen a migration or a movement of people from more of that South Dallas area to an area called South East Dallas, West Dallas area to an area called Forney, and that actually the asthma ED visits that you showed actually really kind of pointed that out as well. We're going to take a little bit of a minute to have everybody kind of soak in some of these questions. I know a lot of people have a lot of questions because this was extremely interesting and really, really helpful. But we do have a little bit of a survey first. Is that right? Lana, we have a survey, right? No. Okay, I was wrong. So I'm going to open this up first to, I have lots of questions and I don't want to monopolize. So if you can just, Joey looks like he already has a question. So I'm going to have Joey ask the first question. Joey is with the Child Poverty Action Lab. So he's involved specifically in housing and is looking at kind of housing patterns with respect to asthma.
Dr. Bhavnani, can you hear me?
Yeah, I can. Thank you.
Okay, great. Well, thank you so much for presenting. Can you go back to the slide that shows the map of Dallas by census tract?
Sure, I would love to. It'll take me a second to pull it up. Sorry.
Okay. While you pull it up, I'll ask my question. So the map, I would say, looks like how I expected it to look. The disparities in Dallas follow similar patterns, whether it's health or education or housing. My question, though, is, are there any outlier neighborhoods that stand out? And specifically, would those outlier neighborhoods be linked to areas with like really strong community organizations, whether those are organizations working on housing, health, youth? On the map, can we see the effects of strong community organizations on asthma outcomes?
Oh, that is a fantastic question. I do not know much about the Dallas area myself. And so we would need to actually address that. We would need your input from you all to really dissect this a little bit more closely and look at those neighborhoods that you're more familiar with, where there's a strong presence of neighborhood advocacy, neighborhood programs to improve housing, to really understand whether they are outliers or not. I can say that this is something that I have been thinking about doing, especially in the Austin area where I'm more familiar with the neighborhoods. But getting a good source of that type of data to do a systematic analysis is something that I've been struggling with. But I think you raise a really good point here. Unfortunately, I'm not as familiar with the Dallas area. So I'm going to keep this map up because I think there's a lot of interest in it. And if you all want to have a discussion about it later, I think that would be great.
Great, thank you.
Hello, my name is Shamar Norris. I have a question for you. I noticed on the slide where you were talking about supporting air filters, you were stating different issues and problems, and I noticed that you had CO2 concentrations. What did you find with the CO2 concentrations in the home? What finding were they high, which would cause the airway inflammation and bronchoconstriction?
So CO2 is a marker of ventilation. So the higher the CO2, the more poorly ventilated the space is thought to be. So it's just a marker of crowding necessarily, or ventilation, which comes from maybe crowding or not opening up your windows, not having good air filtration or air exchange. And so we're interested in CO2 ventilation because I know these viruses that we're interested in are airborne. And so if they're hanging out in the space, then people are going to be more exposed to viruses in their indoor spaces. So it's not necessarily, it's not that we're interested in it as an air pollutant necessarily, it's that it's a marker of ventilation and exposure to viruses. So I hope that addresses your question.
It does. Thank you very much.
Yeah.
So Dr. T has a question. He's a general pediatrician at one of our safety net hospital systems who deals primarily with children with asthma.
Great.
Hi, very nice presentation. Thank you very much, Dr. Bhavnani. Just a comment about the increased reporting in Black and Hispanic children with upper respiratory infections. One thing I think with a lot of my patients, and I think perhaps one reason they might be over-reporting is that due to difficulty in education, I think lots of times what happens is that for a lot of my patients, when they think any kind of a runny nose is an upper respiratory infection. So I work with that population, and so anything that's a runny nose, it could be allergies, it could be smoke exposure, it could be anything that comes out of the nose or anything that produces a cough is an upper respiratory infection. So I do think that could be one thing that might be a factor in the increased reporting of upper respiratory infections in that population. And that's part of the issue, though, is that because lots of times a lot of education is needed to help them to understand the difference between, say, an upper respiratory infection or allergies, and or is this an asthma attack? Is the difficulty in being able to distinguish those different entities?
This is great insight, and I really appreciate your comment. I definitely think health literacy and having an understanding of the difference between cold symptoms and allergy is important. So I completely hear what you're saying, and that's one of the reasons our study team is actually trying to separate some of these infection outcomes. I didn't talk about this today, but one of the things that we're doing is actually strapping wristbands to kids' wrists for a week and asking them to go out and do what they do and trying to measure virus on those wristbands to get a sense of whether there really are differences in exposure to viruses between Black, Mexican American, and white children. We're also swabbing noses, like I mentioned, and so we'll be able to get not just at whether they're reporting symptoms more often, but whether they actually have those infections more often. So I completely appreciate your point, and I think that as much as we can rely on objective markers of infection or viral exposure, we'll be able to maybe really address these questions a bit better. Thank you.
Any other questions? Because I have a ton. What I also found interesting, kind of related to what Dr. T was saying, was that, when we look at these areas, these are areas where there is, there are not enough general pediatricians. There's not enough primary care providers in these areas as well. So that asthma, the emergency room visits might also be exacerbated by the fact that there's just not enough people to go to in order to get the help that they need. And then there's not enough, people to go to in order to get the education that they need as well. Were you able to look at that or control for that? It's specifically in Austin?
I'm so glad you asked that question. I anticipated every time I bring up these asthma-related ED visit rates. So from what I understand, and the physicians in the room can correct me, is that yes, these ED visits can absolutely be affected by healthcare access. But when a child requires hospitalization, my understanding is that that's not really affected by limited healthcare access. And so when we change these maps to just look at hospitalization, we see the same thing. The same patterns prevail. The same, curves of asthma exacerbations, the same sort of map patterns are what we see when we just restrict to hospitalizations. which
That's
should not
really-
be affected by access.
It should not be affected by, I do think it is, because I think I tend to, treat kids very early when they have access to me, when they, send in their messages. But I will, and I think I'm able to keep some kids out of the hospital. But these are children with severe persistent asthma who we have patterns with and all that, and their access is not the same to physicians. But you're correct. There's some data that clearly shows that hospitalizations are not necessarily linked to pediatric care, specifically care to a pediatric pulmonologist. But I still think that it's because of the severity of disease that those particular children have. But it's really, really interesting to hear that and to know that. I also had one more question, if nobody else has any other questions. Okay. The other part of this that I think is really interesting is our look at the social vulnerability scales that we look at, and all of the different factors that are involved in social vulnerability. And I don't understand those scales very well. Are you able to really control with and separate all of those different factors related to social vulnerability, specifically housing, specifically access to care, insurance coverage, things like that?
Yeah, I am glad you brought this up because the more I talk about neighborhood disadvantage, the more my reviewers, the more critiques I get about, so what? We know neighborhood disadvantage is important. What is it about disadvantaged neighborhoods? Because it is important, because unless we address that, we won't really know what levers to pull and what interventions to really think about. So you bring up a good point about the SVI, the Social Vulnerability Index. The CDC puts that metric out, and there are 4 different themes that go into it, like I mentioned. And so for each of those 4 different themes, they do provide different metrics that you can look at and dissect and look at which one is more or less important. We're in process of doing that right now for viral infections among children with asthma. And what I'm finding is that they're all pretty important. Some maybe relatively more than others. I'm finding the socioeconomic theme is really important, as well as the minority status theme. Maybe less so the housing and transportation. And so it's a little hard to dissect that even further, because those 4 components are based on a whole bunch of different variables. And so you can't just pick out one variable there and say, it's this, it's this. They're still pretty broad. So they don't really offer me that much insight, I would say, into what's really going on, which is why I'm saying that these more specific measures of neighborhood stressors, neighborhood air pollution, might be good next steps. So I hope that addresses your question.
Please go ahead to someone else.
Hi, my name is Natalie Kelly. I'm a registered nurse and public health advocate. I did just want to mention possibly diet and exercise amongst these populations. I have had experience, my mom works for the Galveston County Health District, and she works with their Healthy Living, Active Living program, where they go to YMCA and educate the young about healthy living and active. So I was just wanted a consideration of maybe vitamin intake in those populations where there are reduced viral infections, and maybe better diets.
Yeah, you bring up a great point. And I also think that there's a lot of interest in the connection between obesity and asthma, obesity and infection. Interestingly, in that analysis I showed where we used survey data to try to look at the relative contribution of poverty, household poverty, and home ownership, we had also included exposure to secondhand smoke, and we had included obesity in that analysis. And we didn't find that obesity played too large of a role. Granted, we didn't look at vitamins, and we didn't look at other aspects of diet, nutrition. And so, maybe they have a role to play as well. I'm incredibly interested in the role of diet and infection. And so I think that would be a really nice avenue research avenue as well. So thank you for that suggestion.
I have a quick question, and I'd love to hear Dr. Bhavnani speak on it. And then I know we've got a couple representatives from schools in this area too, in case they have comments, following that. I know, Dr. Bhavnani, one of the things you mentioned was the very heightened use of some of the air quality filters that we saw in a lot of settings, but especially in schools, that was really promoted during, the COVID pandemic and kind of as that the following months of that, once people were returning. And I'd love to hear from what you've seen. Was there any continued use? I think there was a sense that, okay, COVID's not the problem anymore. We don't need to use these anymore. And yet so many of those other viruses are still, as we know, a factor. They haven't gone away, and the illness that they cause, not only infectious, but asthma. So I'd love to hear if there was any thought about those filters. Did anyone keep using them? Are they still in existence, or were people just happy to throw away one more, reminder of those terrible times? And after Dr. Bhavnani, I'd love to hear any of our school folks here say whether those are still available, or any thoughts on whether they were useful even during the pandemic. Thank you.
Yeah, great question. And I look forward to hearing from the group about use of these filters in schools, or continued use, let's say. But, I have my eyes on infection data, right? And so what I can see from the infection data is that the seasonality of viruses like rhinovirus didn't really change during the pandemic. Rates went down, but didn't really change that much. So we saw a reduction, but the seasonality was maintained. For other viruses, we all know that we were, seeing RSV in summertime and weird times of the year. So that seasonality changed. But what's important about all these viruses is that they rebounded back up when kids started going back to school. And I think when we largely let go of those community-wide precautions, I don't have my eyes on what's happening all across Texas and schools with these filters. My guess is that it's probably some sort of mixed bag, but I look forward to hearing from others in the room about that.
Thank you. Do any of our school district representatives have any comments on those filters, and whether they still exist, or whether they were, just a great idea people had when we were grappling for any potential solution to the challenges of the pandemic, but not really as feasible to use them?
Well, obviously, I can only speak to our district. What we chose to do in Arlington, our facilities department, as we were returning to in-person school, determined that putting a classroom filter in a small filter system in every classroom wasn't actually beneficial, and would in fact impact the air quality balance of the building as a building. And so what we chose to do was upgrade the filtration for the entire building. And so that has remained in place, because they use a higher quality filter in the filtration system for the whole building, and they've just continued that going forward. So we still have in place what we had put in place when we upgraded during the COVID nightmare, I guess, for lack of a better word.
It's a very good word. Hi, I'm Rita Berkeley. I represent Carrollton Farmers Branch ISD. I'm their health services coordinator. I'm new to them. During COVID, I was up in Grayson County in Sherman, and we did use COVID funding to bring in air filters for the classrooms. And we had them in throughout our district up there. But I do know that once things started dying down, those started, okay, where are they? Nobody could find them. And they were just very sporadic and tended to be in like maybe areas of administration, not necessarily out in the classrooms. And one of the problems with keeping those was going to become funding for maintaining those HEPA filters. HEPA filters are expensive. Getting the UV lights, the ones we brought in had the UV lights. So keeping all of that maintained in school districts, especially, down here in the Metroplex and stuff, where we're all talking about funding, Everything for ISDs comes down to funding. So even to keep, if they remodified their systems throughout the building, there's still an expense attached to keeping those HEPA filters replaced. You have to replace them. You have to. And so when we're looking at bringing in new teachers or building new classrooms because we need more space, things are going to get left to the wayside. Now, I can't speak 100% for the current district I'm in. I didn't think to ask that question when I was going through that, but I will go back and see where we're at. But I'm telling you, across the board on anything we discussed today, it's going to come back to funding on whether or not we're able to maintain any services that's going to help benefit the children.
My name is Dawn, and I'm a nurse case manager with Parkland Health Plan. I have a question about indoor air quality. Since you mentioned that you have researchers who've been going into homes and collecting the dust. A little background for the reason. I work with Dallas County mostly, and back in May last year, we had some significant flooding during some storms that knocked out the power for the city for about a week. And what I learned with our population on the Medicaid program is that a lot of the landlords in those areas for our populations were charging the families exorbitant fees to replace drywall that was damaged. So my question is, for the indoor air quality, have you guys noticed any issues with mold? I know Central and North Texas are a little different as far as that mold content goes, but I'm just curious to know because there's been a lot of education from my end to my patient population to help remedy some of that disparity in knowledge.
Yeah, you bring up a great point. Mold is absolutely on our radar. There's a lot of anecdotal evidence from our study team that mold is a problem, especially in these rented housing and maybe, among disadvantaged neighborhoods and homes. So yes, we're seeing a lot of mold. It's an issue. The problem with researching mold is that there aren't great metrics. It's hard to capture mold. And so I haven't figured out the best way to study it. And I think that that's going to be a big challenge for me, for many of us. But it's absolutely an issue. And I think we need to figure out a way to understand more about it and its effects on both viruses and asthma exacerbations in these kids, because we're seeing a lot of it and it's an real issue here in Texas. So thank you for that point. Unfortunately, I don't have a great answer for you yet, but maybe in a few years.
Thank you so much, and I look forward to hearing your research.
I have one more question I'd love to ask, kind of following up on some of the indoor air quality. And I know there's, been around for a very, very long time, these indoor air quality tool for schools kind of resources that are trying to look at some of the low-hanging fruit that could be interventions to improve indoor air quality. And we know that there's a lot of recommendations around it, as has been pointing out, competing priorities, right? I mean, there's so many other things that are happening that are kind of fires that need to get put out every day. And yet we know that indoor air quality not only affects kiddos with asthma, it affects kids with staff who have chronic respiratory, but indoor air quality has cognitive impacts even at levels that may not be raising flags. So I'm just wondering, as you're doing this research and thinking of some of these other factors that could cause infections, probably not all school buildings have that need. If we want to look at indoor air quality for schools, is there any way that some of this research you're doing might just indicate specific campuses that might be more helpful to look at? And if we can, I know we've got to do it in a very careful way within ISDs because no one wants to, raise alarms about a problem campus or problem facility with issues that can't be solved.
Yep.
I'm just wondering if the data might be able to be used in a constructive way to identify some of those issues and and try to overcome barriers?
These are great questions. So a couple of ways you could back into it without actually measuring air quality in each school. You could use a map like the one that's up here, showing ED visits by tract or by neighborhood and pinpoint, those schools as ones to target. Or we could get even more specific. We know what's indoors, what's outdoors eventually goes indoors. And so we could think about making a map like this, but that shows air pollution levels, outdoor air pollution levels, right at the census tract or the school location. And so we could target those that are in zones, close to emissions or even close to point sources of air pollution, or just have overall high PM 2.5 content outdoors. So that's another way to do it. Another more specific way to do it would be also to think about at the school level what kind of absence data they're seeing. So are they seeing a lot of absences for viral infections, asthma exacerbations, and target those that seem to have a heavy burden at the school level. I think as well, as much as we can make an economic case to the school district, that will also help. So there's something that can be said about reducing sick days. I think that could help.
Thank you so much. If either of our ISD, represented here had any comments, I know it's really hard, but perhaps with support of groups like this, if you see something productive, we'd be really interested in any comments.
I'm okay with data collecting. That's would be helpful because we would need more data to actually start running with any of this. And it would be interesting to pinpoint some schools, maybe within districts. I just think that if we already had something put together, some kind of a program similar to what you already have up here on the slides, that can give us some guidance so that it's not just me going back going, hey, I want to do this. I can say, hey, they would like to. And that kind of changes the perspective. And I feel like most districts are actually open to studies like this to see, because the idea at the end of the day for an ISD is to keep what we say butts and seats. If we can keep the students in the classroom, that's idea. So how can we make that happen? And without collecting more data and information, we won't be able to go down a road full-fledged running, but maybe we can start identifying some things through that. So if you guys want to help me put some kind of graphic or something together, I'm happy to initiate a survey, and then I can reach out to some of my friends and see if they would be willing to collect data for us as well.
It's so refreshing to hear that. Sorry, I just want to say it's really refreshing to hear that. I've been wanting to partner with schools in Austin, and what I understand is it's very, very difficult to partner with ISD. So I appreciate that openness. And if there's anything that I can help with, in the data that I have access to, please let me know.
I will at least have the conversation for you. How about that?
I was going to hold off on talking about this until my presentation later on, but it seems like this is what is in the room right now, and perhaps it'll save me some time later. So what we did at Parkland is we developed an asthma pediatric vulnerability heat map. And what we tried to do is we tried to lay data sets dynamically onto a geomapping heat map that can look at census tract data and specific to zip codes. And we took air quality, we took affordable housing, we took access to healthcare insurance, and actually one of the most protective factors for pediatric asthma is actually the number of females in the population, which actually helps with pediatric vulnerability. And we took a lot of those SDOH or non-medical determinants of health and try to lay it down with the geometric heat map. And so it's right now it's live on the Dallas County Health Department website, and you can actually look at it right now. So if you Google Dallas County Health Department and pediatric asthma, you'll see the heat map, and you'll see that the the map does kind of look like this. It's a higher incidence of pediatric vulnerability to asthma in the southeast corner, but it basically looks a lot like this. So we did take a lot of the issues we were talking about now, such as air quality, affordable housing. No one's mentioned access to health insurance. We try to take a lot of that and put into a heat map that can be localizable to specific areas of Dallas County. So that's something that we tried to we have been able to do at Parkland. So that's something that we could use on a more global level in terms of all of our advocacy efforts to try to pinpoint action items that we could do to Dallas County to address pediatric asthma.
That's excellent, and I love the pass system. And as you probably will mention, our residents in our institution have used the pass program in order to institute to institute unassigned albuterol in the school system. So it's a wonderful program. But we do have a question online.
Yes, hi. So we have a question from Maggie online. She said, "Thank you so much for the presentation. Have you or your group used the US EPA tool Ben Map? It can help to understand what the health and economic benefits would be of reducing air pollution by X concentration, may provide more quantitative data that ISDs can use to justify this work."
So I have not heard of BenMap, but I think that sounds like a great tool as well as the one that was just described. So I think these maps could be used to triangulate those areas where we may want to target efforts, both at the school level and house and community level. So thank you for that suggestion.
Well, I think that's all of the questions, and we're almost at time. I'm so sorry. I got one question. Does your wearable respiratory viral detection, does it detect certain viruses like rhinovirus, or is it just the burden of virus?
I'm glad you asked. So I'm partnering with collaborator Dr. Crystal Pollitt at Yale, who developed these to actually look at COVID, but they pick up any viral RNA, DNA. And so you can test for anything that is airborne that will hit the surface of this passive sampler. So I'm testing for rhinovirus, flu, and RSV because I think those three are most implicated in asthma exacerbations. That testing is ongoing, so I don't have the data right now, but I should have them in the next week or two.
Really, that soon? How many kids were you able to get? Okay, never mind. I'll ask you later.
I'm glad you asked. Thank you. Well, it was a pleasure to sort of be here virtually with you all today. I hope the discussions are productive, and I thank you all for your time.
Thank you.
So I want to give you all a few minutes to soak in everything you learned by Dr. Bhavnati as we transition to a question for the group. And the question is, which of the following strategies would you be the most willing to engage in? We will have you rank the strategies you see on the screen, with number 1 being the one you are most willing to engage in, and 5 being the one you would be least willing to engage in. Thank you all for participating, and we'll take a 15-minute break, right? 15-minute break before our first panel discussion, and we'll return at 11 o'clock. So if anybody wants to use the bathroom, stretch their legs, anything like that.
There's also still breakfast in the back, so you can grab some snacks before lunch. Hello, everyone. As we make our way back to our seats, just want to let you all look at the results from our question on Mentimeter today. From the majority of the people, both in person and online, some of the things at the popular 3 that people want to engage in are community outreach and education, school partnerships, and housing and indoor air quality, which plays a lot into the conversations we already had this morning. So I could please ask you to come back to your seats as we continue with this great summit. Hello, everyone. My name is Leslie Reyna. I am the Assistant Director of Strategy and Outreach for Safer Care Texas. Before I begin, I definitely want to say kudos to our Safer Care Texas team that is helping us with check-in today, and say kudos to my boss back there, Justin Burton. Justin, if you can stand up. He's been great at supporting us and helping our team out, so I want to acknowledge him as well. So next, I want to introduce the moderator for this panel, Kelly Wilmore. So Kelly Wilmore is a tobacco control coordinator with the Chronic Disease Prevention Division of Dallas County Health and Human Services. She also helped them provide those wonderful booklets and bags that you see today. So Kelly focuses on building capacity to deliver tobacco prevention, education, and cessation support. Kelly is highly involved in efforts directed towards the establishment of 100% tobacco-free campus policies across Dallas County, aimed at reducing tobacco use and minimizing exposure to secondhand smoke. Kelly's role also includes implementing programs for individuals diagnosed with asthma and other chronic diseases. She has a master's degree in public health and has managed numerous evidence-based education programs. Kelly will be introducing our wonderful group of panelists. Thank you, Kelly.
Thank you, Leslie. Good morning, everyone. We do have an amazing group of panelists that are here in the front of our room. I believe you all can see them online. So I'll do some brief introductions, and then we have a few questions for them for the next 45 minutes or so. And you can see their wonderful faces on the presentation on the screen as well. So first we have Shamara Norris, who will be sharing our community perspective. Shamara is the founder and executive director of Positive Breathing, which was established in 2011. She's a registered respiratory therapist who specialized in adult critical care and then focused on children's respiratory care beginning in 2007. She was formerly an educator in a local respiratory therapy program, and she's known as the Asthma Lady in Dallas County communities and has partnerships with the city of Dallas, local hospitals, churches, nonprofits, and schools. So thank you, Shamar, for being here. Next, we have Joey Blatt, who will be sharing the child advocacy perspective. Joey is Director of Housing Impact with the Child Poverty Action Lab, a nonprofit focused on reducing child poverty in Dallas, Texas, where he leads research and pilot programs on the rental housing market, property taxes, and the relationship between housing quality and pediatric asthma. His focus is on providing home repair to homes with asthma triggers, including dust, mold, pests, some of those things we talked about a while ago, and children with severe asthma. Then we have Dr. Courtney Barnard, who will be sharing Tarrant County area perspectives, initiatives. Courtney is a social worker by background with over 15 years of experience in promoting health and well-being of children and families. She currently oversees development, alignment, and implementation of community-based strategies aimed at improving children's mental health, caregiver support, healthy lifestyles, and asthma outcomes across North Texas. And then we have also joining us on the panel, Annette Minnerly, who will be sharing school health perspectives. And she just did a little bit a while ago with some of her questions too and comments. So thank you for sharing those. Annette has been a registered nurse for over 38 years. She has been with Arlington ISD for 24, 13 as a campus nurse, and 15 with supervisory responsibility over the nurses and clinical assistants. Prior to coming to Arlington ISD, she worked in cardiothoracic ICU and post-anesthesia care. And then last but definitely not least, we did have Pam Rogers, who is going to share Dallas area asthma initiatives. She had an unexpected conflict, but we have in her place Julianne, who is here, and she will give us some programmatic updates and things going on from Dallas. So thank you all again for joining us. And so we have some wonderful questions for you. Okay, so I know some of you were here last year, and so you may be familiar with some of these programs, but just for the sake of those who are new as well, the first question we'll start out with is, tell us just a little bit about some of the programs and services your organization provides, and then are there any new services or resources or initiatives that you want to highlight this year? So we can start here with Annette. We'll just go down.
Okay, thank you. Arlington ISD participates in the Asthma 411 program. And so we have unassigned albuterol available to our students. And we've actually been doing that for about 17 years. We had an albuterol program that predated our participation in Asthma 411. And we find that to be hugely helpful to keep our students in class. It was given, the albuterol was given over 600 times this last school year, and 240 of those episodes were students that did not have a prior history of asthma, and over 74% of the students returned to class after their treatment. So it's been hugely helpful to us in keeping our students in class learning.
Wonderful. Thank you for sharing that. Shamara?
My name is Shamara Norris. We provide education to teachers, the school nurse, parents, children, and we provide asthma supplies such as handheld nebulizers, masks, and spacers free to the community. We've kind of discovered, just working in the community, a lot of children sometimes visit the ER because they have a broken nebulizer machine at home, or they don't have an extra mask, it's cracked, it doesn't work. And so the first place they take their child is, of course, to the ER to get a treatment. And so, and they don't know how to get the replacement for those parts as a parent at home. So we just provide it for free in the community.
Thank you.
Hi, everyone. My name is Joey Blatt from the Child Poverty Action Lab. CPAL, we work to reduce child poverty in Dallas. We're really more on the data analysis, research, policy analysis work, so less direct service provider. We work on a couple different issues: maternal health, strong neighborhoods, and then I'm on the housing team, so looking at issues related to housing and child poverty. One of those issues is asthma, and so I focus a lot on the relationship between housing quality and asthma. Generally, CPAL, we like to partner with other nonprofits. We work a lot with different government agencies. We can help organizations with their data requests. So if you have anything like that, happy to work with you. Specifically with asthma, I've been working to develop a home remediation program. So partnering with the home repair service provider. And we just had our first visit with a contractor to a home in West Dallas last week to figure out what home repairs this family needs to improve asthma outcomes. And so looking to expand that project as well.
Thank you. Courtney. Mhm.
Hi. Hi, everyone. I'm Courtney Bernard. I'm with Cook Children's in our Center for Community Health. At Cook Children's, of course, being of a healthcare system, we have a wide range of asthma services and supports that we provide to our patients, our health plan members, and the community at large. One of them that I oversee at the Center for Community Health is our Healthy Homes Asthma Program. This is a program with community health workers, and they work one-on-one with families who use the emergency room for their asthma care. So folks who are coming to the ED 3 or more times in the last 12 months and probably indicates they need some extra support. So our team of community health workers will go into the homes, do a home environment assessment, and work on reducing those triggers in the home environment. So providing those cleaning supplies, pest control services, all the things to take care of those triggers in the home environment. So this is also paired with the, of course, clinical services and education services that Cook Children's provides to all of our patients. So we have our neighborhood health center serving our Medicaid population, along with primary care physicians, referrals into our pulmonology clinic. We have a brand new high risk asthma center as part of our pulmonary clinic. It's incredible. It just launched in May, so we're learning all the things on how to best service these kiddos who are at a higher risk for severe exacerbation. So we are able to partner Healthy Homes with that high risk asthma center to better serve families there. And of course, we have our respiratory therapists and asthma educators on staff to provide kind of that full continuum of care around asthma. We're also, another way we extend into the community is working with our school partners, our independent school districts. So just as Annette mentioned, we do partner with the Asthma 411 Consortium in Tarrant County. Cook Children's provides that stock albuterol and the pharmacy services, along with some education with our other partners involved in that. And then we're looking to extend the supports that we offer schools to include more around addressing those emergency responses on team, on site as a whole team, not just with school nurses and the health staff, but athletic trainers and coaches and teachers, anywhere that's outside of that nurse's office where, of course, emergencies could happen. So supporting schools in their emergency response.
Thank you. And then Julianne.
Morning. So I'm with Children's Health with our asthma management team. We have several different services we obviously offer inside the hospital and outside the hospital as well. Inside the hospital, we do have in place inpatient education coordinators on both of our campuses to provide education before hospital discharge and in the ER, depending on where needs arise. And then we do ED phone calls for both campuses within 48 hours for anyone who comes in with asthma, or maybe they're just seen for a virus, but they have a history of asthma or coughing or whatever, to hopefully reduce readmissions. Our team outside of the hospital are, well, I guess I could say about the clinic too. So we do partner with the pulmonology clinic with their high risk asthma clinic as well. That runs twice a month. With them. And then outside the hospital, the main program, or I guess our biggest program that we do, is our asthma management program. We offer 3 to 6 month programming for anyone within the state of Texas that meets our criteria. And they can be referred by any provider. So their pediatrician, their specialist. And we do biweekly phone calls with a nurse and then virtual home visit or in-person visit with a respiratory therapist. That's free service for kiddos from 2 to 18. And then we have our Asthma at Home program. That's kind of like an extension of someone that was recently admitted or in the ED that maybe needs just a little bit of follow-up, touch base, and kind of continuation of their care that was received in the hospital. And so an RT will reach out to them to do a follow-up phone call or maybe a visit if they did not see our inpatient care coordinator inpatient educator. They'll have a little bit of extensive phone call after hospital stay or ED. And then we also, I guess I should mention, partner with school services around the area. And so we do several different types of partnering with ISDs. We will go to in-service days for our nurses and staff there to educate about asthma, medications, treatments, offer some resources to them. We do back to school events. We do health community fairs. So we're kind of all over the place, wherever we need to be. I'm sorry?
You do school nurse education?
Yes, yeah. And so I know a lot of school districts or several school districts now are out on Fridays. And so we do, pop in on those Fridays to kind of provide education to school nurses to provide support there as well.
Thank you so much. So as you can see from the title of this segment, cross-sector perspectives, again, just as a reminder, we have various representatives here. So we have school district, hospital, clinic, just community-based, working directly with our families, just in the community setting, housing. And so for the next 30 minutes or so, I have some set questions that I'm going to ask you all that we can get through, but the audience online and in the room, if you all have questions too and just want to open the discussion, because as we said, our theme is the power of partnership. So we all work better together. You may have some questions for them or some ideas of things that we can do. So the first question, it goes back to our recent presentation that we had by Dr. Bhavnani, and just we talked about it a little bit. You all had some great questions earlier too, but thinking about some of the information and issues that she brought up in her presentation, how do some of those concerns, relate to what you all are seeing among families and children? I mean, did any of that resonate? That you're seeing some of that same data or situations as you're working with families and children? And any of you can go first. Thanks, Shamara.
It does resonate, especially the indoor quality, that housing piece where she said homeowners versus, leasing. What I have seen is the leasing part, right? So you have families that are leasing these places, and if you ever gone indoor in some of the homes and seen what I've seen in the homes, my mind just picks up on a family of the home that I saw. And then they try to talk to the landlord to get the landlord to come in and mitigate and fix these problems and issues. And when they do, they get penalized. Basically, they come after them and attack them and threaten them with, we're going to put you out. And where they live at, they're paying really low income rent to live there. They're already, it's pressed for them as far as financially, and then you're being told that you'll be put out if you complain or report. And so that was a huge piece that I can say that I've seen, and it's just disheartening what to find out that the landlords are doing. And then, so and then if they do try to help them mitigate, I'm just going to give an example. It was a home that had a lot of mice and rat feces in the home, and the mice and the rats were biting through the wall and had holes, and you can see them coming and entering in the home. And then when they did complain, they just gave them a sticky pad and said, here, this is mitigation. And that's really not mitigation, because the sticky pad doesn't cover all the mice in the home that I
Right.
saw. So that's something I would like to mention.
Yeah, thank you for sharing that. And we'll get to that too. Courtney, did you have?
Well, I was going to add on because very similarly, our Healthy Homes program, we hear a lot of the same concerns from our renters. A large majority of the families in our program are renters. And so the same kind of hesitation with landlords we hear from. We also know landlords tend to be landlords for renting as well as multi family complexes, the interventions are a lot more difficult. Again, to get not only the landlord on board with being able to provide a service, whether it's pest control or carpet cleaning, you have to go through layers of approvals if they're responsive at all. And then also just knowing that you can do all the interventions for one unit, but if the neighbor next door is smoking or has cockroaches or some infestation, it's going to still impact the family in your unit that you're working on. So we're limited in what we're able to do or accomplish in that sense. So that's a huge challenge.
Yes, thank you all for those comments. And I know we extended some invitations to just some multi-unit housing managers and complexes. I don't know if we have anyone virtually online, but if so, we would love to hear from you at some point. Again, we need everyone at the table to address some of these issues. Joey, or Julianne, or Annette, did you have any comments on that particular topic in Dr. Bhavnani's presentation?
For me, Dr. Bhavnani's presentation really just underscored social determinants of health, non-medical drivers of health, and their impact on asthma. And so when I'm coming at this from a housing perspective. I'm a housing policy researcher type. And so that's really my vantage point when I look at asthma, and to see it, reinforced by Dr. Bhavnani for me was really helpful. For the owner versus renter aspect, I never heard that stat before that she shared. So that was really great to hear. We've at CPAL, we've heard a lot of these challenges when it comes to working with a renter population. So for our pilot, we were focused specifically on finding a homeowner to begin this pilot. And so the issues are in both populations. They might be more pronounced in a renter population, but we can see it in both populations.
Thank you. Go ahead.
I mean, I feel like during our programs, we're pretty consistent with what everyone else is saying here and what we found in the presentation. We screen for SDOH in almost every phone call. We strive for every phone call, but I would say we're pretty close to that. And we find barriers, to care and issues in housing specifically pretty consistently with our program participants. Most of them can be pest related. Of course, smoking, like you were referring to, maybe not smoking within that household, but are we in an apartment complex where neighbors smoke? I definitely had several issues with that with, previous patients. And then even, getting them to change out air filters. I know we talked about air filters in school districts and things like that, but having consistent landlords that will, make those changes, kind of make those efforts, it can be challenging.
Thank you for sharing.
I think from the school perspective, the thing that resonated the most with me, and we definitely see, are the parents that are unable to take off work, and so their child comes to school ill, and sometimes very ill, particularly if they have multiple children and very limited time off. And that happens both in families where they're economically stressed and also just in families where the particular employer that they have is not receptive to the employee being away from work. And so they're concerned about losing their job or being demoted or penalized in some other way if they miss work.
You bring up a really good point, and I know I've talked with my team about this too as we're trying to think of policies and things. I know policies are difficult, but maybe we need to see if we can focus on some workplace policies. I did work for a previous employer that one of their benefits and perks was one, they had a day off that you could take for if you had caregiving responsibilities, whether that be a child or a parent or someone. And then they also had, it was My Health Matters days. So whether, again, that was you or another family member had medical appointments and you still had to use time off, but they gave us extra time off and it was once a quarter or whatever it was, so that people didn't feel like they can't go to the doctor to take care of their own health or someone that they, so there are some employers there, and maybe we can, as we're working on policies and talking with companies, to have them, possibly think about that. Yeah, absolutely. Asthma education for sure. The next question, thinking of some of the unmet needs, everybody always asks that question, what keeps you up at night? So what are some of the challenges that you see, the top challenges related to asthma needs, asthma related needs that you see the children and families facing? So just top challenge? We know there are a number of them, but what would you say right now are some of those unmet asthma-related needs? Go ahead, Julianne.
I feel like Dr. Afalabi hit on it a little bit earlier, but just access to care. So
Mhm.
a lot of my patients, in our programs, if they're having issues, it's pretty often that I find a parent will say, well, they can't get me in until such and such date, or my physician can't do a same day appointment. Well, for an asthma flare up, we can't wait all the time, or most of the time I feel like we can't. So, access to care can definitely be an issue, and including, is the parent home? Can they take off of work? I feel like some of that's changed since COVID, because a lot more people are working from home. And so I have seen that benefit from COVID as, those kiddos are able to stay home because now parent is there, they can work and do treatments and kind of double dip at the same time. And so that has been, I feel like, a little bit helpful. But still, are they able to do that and get them to the appointment? Probably not, right? Because then they would have to, ask off work or take PTO or whatever, where they don't have to do
Mhm.
that if they're just treating them at home. So definitely access to care is continues to be an issue.
Thank you for sharing. Anyone else? Some of the top challenges, unmet needs that you're seeing?
I think, again, in our Healthy Homes Asthma program, so many of our families, yes, the access to care is a challenge. And then even when they have that access to care, it seems that physicians have such a limited time with their patients. And so families will come out of those appointments not knowing how to take their medications or fully understanding. And then being able to share that with the other caregivers in that child's life or other care settings that child is in. So again, having an inhaler at home and for school and at grandma's house and a spacer for all those places, and everybody understands the asthma action plan and how to address it. That's a big thing to make sure your child's whole system of support is up to speed and has the tools they need to care for that child. And so that seems to be a really big gap.
Thank you for bringing that up, and that might be something we can discuss too in the breakout session too. How can we have the whole support team and the whole family up to date on the asthma action plan and what that child needs? Thank you. Shamara?
I know she mentioned stressors, and stressors in the home could be, we don't have enough food for the month, or I don't have, money to pay my entire rent. That's a stressor on the parent. So that takes away from the health of the child when you have different stressors in the home. And so that one keeps me up at night.
Mhm. Thank you for sharing. Any others?
I'm just a broken record about housing and housing quality. And so when I think about the unmet needs, I think about specifically funds for, I would say, like the more intermediate home repairs that families really need. So things like a roof repair, things like a new bathroom, which could be $5,000, $10,000, which in the grand scheme of a home repair is moderate, and the grand scheme of an intervention is pretty expensive. And it's certainly prohibitively expensive for a lot of low-income families.
Right. Thank you. Okay. Annette, do you have anything, or we can go to the?
I think our families, one of their problems is access, and in some ways in Arlington, it's transportation as well, because there at one point was no public transportation of any kind. And we do now have the VIA system, and that has helped with that tremendously. What we're trying to do as a school district, we now have telehealth available on all of our campuses. And that certainly doesn't replace a primary caregiver, but it does give us an option to address an urgent need. If they can't get an appointment in
Mhm.
the next day or two, we can get them seen if we can get the parent to agree. And sometimes that's a challenge too.
Sure.
So I wanted to ask a quick question about access and telehealth. So I think telehealth has been really helpful in a lot of different ways. I know that Children's Health has a telehealth program in schools as well, and in that the asthma management program does a lot of telehealth that actually helps to improve, I think, access at some points in time as well. But what are some of the barriers you see to telehealth as we start to, as we ramped telehealth up?
I think the primary one that we see is either buy-in by the nurse. is one. And then the parents' willingness to participate. And one of their big concerns typically is what's the cost to me going to be? The particular service that we use is covered completely by Medicaid, and parents that do have insurance, they have a service line. The parent can call and find out precisely what their personal copay is going to be before they set up for the visit. And that's not the nurse's responsibility to have that conversation with them. And that has really helped us with nurse buy-in, is if the parent's having difficulty registering for the visit or filling out the consent information or any of that, the service has a number that we can even ask them to call the parent, and they'll call the parent and assist them. And so taking that responsibility off the nurse's plate has helped us with nurse buy-in. But it's really the biggest challenge is getting the nurse willing to offer it and the parent willing to accept it.
Great, thank you. So what is one thing that you wish all of these wonderful attendees here at the summit understood about your day-to-day asthma-related work? So just thinking about the other sectors in the room, since we have multiple different sectors here, what do you wish? I believe we have individuals from, some managed care organizations here, hospital systems.
I think for me in general, Shamar touched on this earlier, but so much of the care we provide to our families who have asthma is focused on the social determinants of health. It's focused on these other stressors that are present in the family's life that's keeping them from being able to manage their child's asthma well, or being able to give it as much attention and focus as we might want them to give. If it's not, if their child's not in an active asthma crisis, a lot of times that falls down on the list of priorities, given that there's these other needs like dinner on the table, how am I gonna cover my rent this month? How am I gonna cover these shifts and childcare and all the other things? And so I think what it sounds like so many of our programs do offer across the range is having that support us through community health workers, where they're not only focused on asthma, but these other needs that the families are trying to work through. And then so for others in the room or in other sectors, yes, it's about asthma, but it's about the whole family and the whole life experience and how we can impact all of that together.
Great, thank you so much, Courtney.
I'm going to speak not from a executive director of a nonprofit, but from a respiratory therapist who still works in the hospital, who's worked in Dallas County, who's worked in Ellis County. I've kind of worked a couple of places. I've been doing this for 25 years. And what I see in the emergency room when families bring their child in is they don't have the education that they need. Like she said, there's limited time that a doctor can see a patient, and she's not always able to provide the one-on-one education that a parent needs to educate their child. And I just had a conversation with a colleague of mine at work, and she was saying that her son died at the age of 10. She was a respiratory therapist. That's what made her become one. And she said she wished she had the education and the knowledge that she has now in order to help her son then before he had passed. And so that kind of left a huge impact in my mind because she went to school after that because she didn't have the education. None of her other children have asthma. She's got two daughters, but to lose her son at 10 years old from asthma left that huge impact, and it was education. She said all the things that I learned in school I didn't know, and if I had known, maybe my son would still be here today. So.
Thank you.
Day to day, how asthma is one of a handful of issues that CPAL works on our housing team. And so for me, I'm still learning about this topic. And so I so appreciate coming to conferences like this and being able to connect with people who are working on asthma and hearing their stories. One of the main issues that CPAL works on is evictions. And it sounds like a lot of families are, and we've seen this as well, that families are very scared of their landlords and they're fearful of evictions. There are resources, especially in Dallas County, for families facing evictions. Not to get into the nitty gritty of how evictions work, but once an eviction has been filed against the family, that family can access a lawyer who will represent them. We see really, really strong outcomes when families have lawyers in their eviction hearings. So there are resources. A lot of what's being described with tenants being fearful of their landlords would fall into like quote extra legal evictions. So basically evictions that don't follow the law. To get an eviction, you have to go through specific legal steps, but a landlord can, against the law, basically just lock out their tenant. Those are probably the most vulnerable populations that experience that, and that's a harder problem to solve. So, but there are resources again for tenants facing eviction, and I'm happy to connect with people to share those resources.
Thank you. Oh, yes. Go ahead, Annette.
I would agree that education is definitely our biggest challenge, and not only of the parents and the students, but also of the staff on the campuses, the teachers, particularly the coaches, although that has gotten better as our athletic training department has also started helping us with this, to recognize that the student who says, I need my inhaler, needs their inhaler. They're not just trying to get out of running or trying to get out of whatever activity might be going on. If they say they need their inhaler, they need their inhaler.
Yeah, exactly. So we have just about 10 minutes left. One more question, and then we can open it up. I know Dr. Alsop has a question, and then if there are any others in the room too. But we're all here today. There's some online too. What opportunities might there be for collaboration across sectors represented here today?
For CPAL, we have a really strong data team, and we're happy to work with other organizations on their data needs. And so, if happy always to connect on that. When it comes to other sectors, I've been able to connect a lot with the Non-Medical Drivers of Health Consortium out of Rice University, and so they have a conference in December that I attended. And so I think that was really helpful for me. When it comes to housing issues, I think there's obviously a lot of potential there. And then, I don't work like a ton with like the legislature, but there's so many potential legislative solutions. Some have, I think, higher chances of getting traction than others. But reforms to Medicaid, things like getting more housing interventions in lieu of service packages, potential changes to Texas property codes, but the apartment lobby is really strong, and it's hard to get positive things on that. But there's just a lot of opportunities for cross-sector collaboration.
Thank you. Any others?
Yeah, I'm glad I'm sitting next to Joey today because I have so many questions and thoughts, even though we're in two different counties, but to look at housing and health together. So I'm excited about that. But also, and hearing from you from the school perspective, again, how do we, knowing that at Cook Children's, we have these clinical pathways and other resources that we want to partner with schools to help prepare the whole school campus, address these on-campus emergencies, and respond to our kiddos with asthma. So having those insights from you and others in positions like yours to better understand what those school needs are and how we can navigate that and best come up with a solution together.
Thank you. Any other ideas of how we can all work together more?
I think generally like the housing policy advocacy groups in Texas, they're pretty well connected, but I think they would benefit a lot from greater collaboration with the health advocacy groups. I think framing, sometimes housing issues get framed as health issues, but I think increased framing of housing issues as health issues and as children's health issues is able to really penetrate and really to cut through. And so I think, again, a lot of potential there.
Thank you. Did you want to ask your question? Dr. Awesome?
I think it's really just honing in on some of those things that I've just mentioned with the vulnerability of these families who are living in terrible circumstances that they're watching threaten the life of their child and their ability to be educated and go to school, and yet they are not in a position to advocate for themselves or their families. And I know speaking to, I believe it's David Rush, who was in the Tarrant County side, where he's, called me and said, I don't care anything about asthma. I've got to tell you, I'm in the school system, and I was told to follow up with families with high levels of absenteeism. And, he had visited then with the family. He saw what the family was living with. And then he said, I'll speak to your apartment manager as a representative advocate for the changes that are needed. He's eventually, I think, gone into that full time is what he ends up doing outside. But I think that, those things that are just, I know you all are working with it every day, and yet I don't feel like, as somebody who's more in higher ed, public health, healthcare systems, I've got, I would love to hear more from you all so I know how to better incorporate that and raise awareness. And when we talk about the issues and health problems that we're saying, and everyone needs to know what's going on with the housing situations, so that that's not happening, in the dark, so to speak, with these vulnerable families being impacted and really not being able to speak up. You guys are doing fabulous work, but I do think that those of us who are in the health systems, in higher ed, and in public health could do a lot better job than we currently are of advocating. And I'd love to hear how we can start doing that.
Oh, go ahead, Shamar.
I'd like to say, I'm just going to repeat back what I saw. I don't know how to say her name, Dr.
Oh, Bhavnani, yes.
Thank you.
Mm-hmm.
There is an epidemic of asthma exacerbation when children return to school, driven by upper respiratory infections. An epidemic. School is where it's at. The connection is with the school system. We have to connect somehow, partnership. All of our entities somehow have to partner with the school. I think we have a better understanding what an epidemic is now that we've gone through COVID-19. They're calling this an epidemic. So I think schools,
Yeah,
partnership.
absolutely. Thank you. Oh, yes, I was going to open it up to see if there were any more questions in the room that any individuals have. Dr. Afolabi, you can, and then, yes.
Well, really, it's what is Dallas County doing?
The question is, what is Dallas County doing?
Yeah.
The health department?
Yeah.
Oh.
Can you describe like your program and everything? I'm sorry.
It's okay. So we do have some of that coming up in Dr. Tremolo's presentation later. I don't know if anybody else on our team would like to. Walter, would you like to answer what is Dallas County doing? Would you like to share?
Good morning. My name is Waldo Amanisha. I'm the Assistant Director for Chronic Disease Prevention at the Dallas County Health Department. When it comes to asthma control, we have a couple of programs. One of them is asthma home visit. Our asthma home visit program is virtual. And we also have asthma self-management education. We promote 100% tobacco-free the campus policy. We try to work with apartment complexes, workplaces, educational institutions. So there's a wide range of programs, both from the policy environment side as well as direct services. I'm sure Dr. Tremolo would talk about some of the programs that are undergoing in Dallas County, but I would take this opportunity to ask Courtney, have you done any analysis on your asthma, the impact of the asthma home visit program? The reason why I'm asking this is ours is virtual and we're planning to implement in person. So based on, the kind of resources that the two programs would need and the probably increased resources that we might need, is there any like a significant increase between the two approaches? And that would be really curious to know. Thank you.
That's a great question, and thank you. So we do for the Healthy Homes program, we do a pre-post analysis of ED and urgent care utilization. So in the 12 months prior to enrolling in our program, how many encounters and the associated charges does a child have? And then for the 12 months after program enrollment, what is that? And we have seen consistently across the last 6 years a decrease of somewhere between 80 and 85% of ED visits, and the charges it follows suit. And with urgent care, it's been somewhere between 75% to 80% decrease. So we're seeing those changes. Your question about in-person versus virtual, we've done both and still do both versions. Not all families are open to having us come into their homes. That is how the program originated, and it's our preference because you see so much more when you're in that space. However, our team is able to successfully conduct assessments and work with our families over the phone. We tried Zoom. That did not go over well with our families. They were not interested in a virtual in terms of video conferencing. But we see those same reduction rates, regardless if it's over the phone with a couple of in-person, like we might go to the home to deliver some supplies or meet up with the family one-on-one to exchange supplies and see them. But we see that same reduction.
Oh, yes. Go ahead, Dr. T.
Yeah, I have a question for Mr. Blatt. I'm excited to hear about your work, to know about your work with CPAL. So my question is this. So I work for Parkland. I'm a general pediatrician with Parkland, and I think most of y'all know, but we have 16 community clinics, mostly working with the vulnerable population in Dallas County. We have about 33 pediatricians that are trying to manage pediatric asthma in those populations. So my question is this, Mr. Blatt, I'm asking if we could formally collaborate with Parkland. I'm wondering if you mainly work with data collection, because if not, we also have a significant number of patients that we take care of that have housing difficulties and housing issues. And I'm wondering also if you work with, because I'm sure I can probably think of 5 patients that I take care of myself that are having housing issues, and I'm wondering if you provide help with resources or mainly data collection. We could help with data collection, but I can tell you we have a lot of patients who would need intervention with their housing situation that they're in.
Okay, yes to partnership and collaborating. So fantastic. For data collection, we on the current pilot we're doing right now with the home in West Dallas, CPAL is really leading the data collection part, and then we'll hopefully over time be able to develop as we do more homes, our own roster of data, and sort of mirroring what Courtney's done with before and after intervention and looking at urgent care, ED visit, also the economic mobility indicators like days missed of school, parents' days missed of work. So we're interested in all those metrics. In terms of connecting to resources, CPAL, we've been working with Hearts and Hammers, a home repair agency. And so they're the ones that organize the contractors, the mold specialists to come out. And so depending on the home, owner, renter, kind of how severe what type of condition the home is in, any of the homes could potentially be a fit. All the homes could be a fit. That's something that we can discuss. And then when it comes to sharing resources, so I feel like whenever I'm in an asthma room, I always asterisk, I'm not a public health researcher. I'm not a doctor. And then whenever I have eviction conversations, I'm always I didn't go to law school. I'm not a lawyer. So I'm not a lawyer. I can't represent people as they go through eviction hearings. But I can absolutely share resources and connect them to those people who do help with that.
All right. Thank you so much. I want to thank Kelly for moderating this panel and to our amazing panelists for the knowledge and perspectives you have shared with us today. Let's give them all a round of applause. Thank you so much. So I don't believe we have any questions online. So we will now have a break for lunch. I want to thank Children's Dallas for sponsoring that delicious breakfast. And now thank you to Cook Children's for sponsoring the wonderful lunch we're about to have. There are vegetarian and gluten-free options. And also please visit our community resources table located in the back of the room. For those of you online, we will be displaying our community resources slideshow on screen during lunch. And for those of you who haven't had access to the agenda, in the check-in table right in the back, you will see a poster with our wonderful keynote speaker. There's a QR code that you can scan that will take you right to the agenda for today. So we will return back at 12:15 p.m. Thank y'all.
Leslie, I just want to add something real quick as we're going to lunch. We said we have multiple sectors here, so as you're grabbing your lunch too, talk with someone, get a phone number or an email address that you did not have when you first got here too, so we can stay in touch and connected.
Hello, everyone. I hope you all are enjoying your lunch. Just letting you know, we will get started here in the next 2 minutes. So you can continue to eat as we start our next presentation, but just letting you know, especially for those who are going to be speaking, we will be starting in the next minute.
Welcome back, everybody. We hope you had a great lunch. My name is Juana Escobedo Bermudez. I'm a community health worker instructor and program project coordinator for Asthma 411. And now I will welcome back Dr. Alsop, who will be moderating our next panel discussion focused on metrics.
Wonderful. Thank you so much, Juana. And I have a pleasure of introducing another great set of panelists here. First, we have Savannah Panagopoulos, who is our community health analyst with Cook Children's Center for Community Health. Savannah is passionate about improving well-being and equitable access to healthcare for all members of the community, especially those most underserved and underrepresented. And Dr. Cesar Termelo is Associate Medical Director for COPC Central and East Regions at Parkland Health. Dr. Termelo received his undergraduate degree from University of Notre Dame, completed medical school at UT Southwestern in Dallas, and finished residency at Children's Health in Dallas, and has been practicing at Parkland as a general pediatrician for 23 years, married and has 3 children, all born at Parkland. Join us in welcoming our panelists. And we will also start with Dr. Termelo's doing his presentation on some of the metrics from the Dallas County. We'll have Savannah will be presenting some metrics from Tarrant County and Cook Children's, which is of course the broader system on this part of the west side of our region, and then having a brief conversation following that about considering a regional perspective on our metrics. Great, thank you so much.
Thank you very much, Dr. Alsop. So I'm going to talk about our what we've been doing with our pediatric asthma program at Parkland. We've named it Breathe for Life and Learn for Life, but basically it's our CHNA asthma program that we developed at Parkland. Next slide, please. And I realize a lot of you have already heard a lot of this before if you were here last year, but I'm going to try to give a little bit of a just couple background slides about what we're doing. So we are doing a collaborative effort with Shamara with Positive Breathing, with PCCI, who does a lot of our data collection and data analysis, and also Dallas County Health Department. Thank you for Waldo and Kelly for the work that you have done, collaborating with us with our patient population, especially with the home visit program or the virtual visit program that y'all have been doing. Next slide, please. So just as a background, the things that we are doing with our asthma program is that, first of all, we have a risk prediction model for a lot of our patients that tries to predict which of our patients are most at risk for developing an asthma attack within the first 90 days. What we do is we try to use certain subsets of certain sets of dynamic data that's going on in the background while in the background when we're not seeing the patients, to try to develop a model to predict who might have an asthma attack. And then from that, we're able to develop monthly risk reports that are fed to our clinical teams. We have an asthma program manager, Jason Allen, who could not be here today, but he and another respiratory therapist, they take that list of patients who are having or at most at risk of having an asthma attack and reaches out to them. We reach out to those patients, and then they do an asthma control test over the phone to see if they're in fact having active symptoms of asthma and whether they need to be seen. And if any of those patients do need to be seen, they bring them into the clinic, and they know ways to kind of work the system to get access into our system to get seen. And then we also have a clinical workflow integration. So a lot of those patients who are most at risk of having an asthma attack, they'll flash a BPA on the screen for a patient who is at risk for asthma. So if I'm seeing a patient for a headache or for ADHD or something unrelated to asthma, there's a BPA that shows up on the screen, or a best practice alert that will alert me to the need to address asthma, and that I need to manage it at that appointment or schedule a follow-up appointment to address the issue. And then also we have a text messaging program for all the patients that are in our program that will remotely monitor how they're doing with their asthma. So a lot of this I talked about last year, so a lot of y'all might already be aware of this. Next slide, please. So this is these are the different predictive values that we're using. You can see that a lot of these change dynamically. And so we try to run this in the background when we're not seeing the patients. And so these things are also weighted into a way that develops a statistical analysis of who might be having an asthma attack. Next slide, please. And then this is a slide that shows what our text messaging program looks like. The mother in this video actually is a patient. Her children do have pediatric asthma, and she gets a text message every week, and for some patients is every 2 weeks, and it's asking them 2 questions: how is your asthma today? And also, how many doses of controller medication have you missed? And once again, that is also compiled into a report, and that report again is fed to our asthma respiratory therapists who manage our program and manage our patients, and they once again reach out to those patients to see if they need to be brought into the clinic. There's a QR code there. We do have a Instagram reel that shows how the text messaging program works, and it kind of talks about she talks about how it's helped her children. Next slide, please. So that's a little bit how we are using metrics in terms of trying to put patients and stratify them to who we need to reach out to, because I know that when I see a patient and after I put them on, even if I do as best I can with asthma education, and even though I might put them on the right medications, once they step outside the four walls of my clinic, I have no idea how they're doing. I might not know until I get a fax from the ER that the patient showed up in the ER. I really have no idea. So at least this is a way that we can try to predict which patients might have rising risk for pediatric asthma, and we can also remotely follow whether they might be having issues or not. And with the program that we have seen that it has been effective, and that 36% use of the ER has been shown in our patients that utilize our program, and 6% less asthma hospitalizations occur in the patients that utilize our program as well. So we have seen that it has been effective. Next slide, please. So one thing that we're trying to do on a month-to-month basis is that we do keep track of 3 particular metrics that will kind of help us to see outside of the metrics that I showed you. These are the 3 metrics that we try to keep track of on a month-to-month basis. So the first one is the asthma therapy. It's named asthma therapy, but it's the number of patients who have persistent or severe asthma that are on a controller medication. So we put the bar pretty high at 98%, or a little bit below it at 94%. Another thing that we're trying to do is we try to set a goal in terms of the number of patients that sign up for our text messaging program. So on the far right-hand side, you can see we're up to 14,000 patients who are signed up for the text messaging program. One thing that's difficult, it's hard, especially if you're getting a text message every week, it's hard to keep them engaged every single week, and so that's not always easy to do. So it's large numbers of patients that have signed up for the text messaging program, but it's not very easy to keep them engaged and to keep them sending replies that their asthma is doing well. But I think it's something that's important. As I think I mentioned it last year, we do have patients that they're outside of the system. They don't have a follow-up appointment, but in this fashion, we're able to track down those patients that need care. And I don't remember if I mentioned this before, last year, but we did have a patient who was seen by the cystic fibrosis clinic at Children's. They missed their follow-up appointment. They lost all their medications. They're off all of their medications, but luckily with the text messaging program, we found out that the asthma was doing poorly. We brought them into the clinic. We restarted them on their medications and referred them back to the Children's cystic fibrosis clinic. And that patient was completely fell through the cracks. The last metric that we try to keep track of is flu vaccination. We know that asthma patients are at risk for asthma attack if they don't get their flu vaccine. And so we set a metric. We tried to set a goal of 62% for our pediatric asthma patients to get the flu shot. This past year, we were at 60%. So we focused a lot of outreach, and we tried to focus whenever a patient came into the clinic that they get their flu shot. And we also try to make it as accessible as possible to get their flu shot. So even if they didn't have an appointment, if a patient were to walk in and say, can I get the flu shot? We try to have a nurse available. We try to have templates available so that a nurse could give the flu shot. So that way it doesn't have to be within the context of a visit, which isn't always easy to do. So we got our flu vaccination up to 60%, which wasn't meeting our goal, which was arbitrarily set at 62%. But I think the CDC had in terms of April, their numbers were at 49% for the general population getting the flu vaccine. So I think I'm happy with that at 60%. So that's just an example of the 3 metrics that we try to track month by month to try to guide us on what we need to be doing with our asthma control program. Next slide, please. So I mentioned this before, the North Texas Pass pediatric asthma surveillance system, and y'all could play with this and you could see all the different data sets that we're using in terms of trying to know on a more systematic level and a high bird's eye view level in terms of where are the needs in our community to try to be able to address pediatric asthma. We took different data sets such as, which I mentioned earlier. So what we're trying to do is we're trying to use this to target our efforts in Parkland to address areas of opportunity in the county and within our system. And for now, and this was also published in the New England Journal last year in August. So that was new since the last time I was here. Is this PASS system was actually published in the New England Journal of Medicine. So what we are trying to do actually is based on this. Next slide. We're trying to do what y'all have already started doing, which is Asthma 411, because we do not have Asthma 411 in Dallas County in the DISD. So y'all are ahead of the game with Arlington and with Fort Worth that y'all have Asthma 411 in your schools. I can tell you that with a lot of my patients, it's really difficult with the number of letters that I need to write to let schools know that this patient needs to have albuterol on hand at the school. And not all the patients will let me know that I need to sign that letter. So if they show up at the nurse's office, they can't give them their albuterol. So hopefully that's something that we can get started in Dallas because it is not in operation. So Dallas ISD is engaged and they want to have the Asthma 411 in their system. So we're trying to get that together, but there's a lot of groundwork that we're trying to set. We're trying to engage our legal team. We're trying to work on the MOU. And of course, all the logistics that y'all have already worked through, we are trying to get that. We're trying to get that in our system. So in terms of metrics, we're using PASS. We're using PASS on kind of a metrics and PASS on a high level, which led us to Asthma 411. I'm thankful for the children's program because really it was 4 residents who kind of looked at the PASS system and thought that the best thing that we could do right now for Dallas County is Asthma 411. And Shane and Dr. Afolabi has been helping us as well. Next slide, please. Just a little bit of an update of what's been happening. Kaiser Permanente looked at the asthma program that we have and awarded us a $750,000 grant to try to transpose what has been done at Parkland to other FQHCs. So this is completely outside of Parkland. So what we're trying to do, next slide, is take a lot of the metrics through that we use through our risk predictive model, and would it be able to be transposed into other healthcare settings, particularly Foremost FQHC and Los Barrios FQHC. So they're very different systems. Their EMR is different. Their ability to, our ability to get the data is different because they don't have Epic. They have two different EMRs. They do not have the ability for a best practice alert as clinicians are seeing patients. And of course, the clinical settings are different as well. We are lucky at Parkland that we have two respiratory therapists that help manage our patient population, and they can manage these risk reports. However, they do not have available respiratory therapists that can help out with that. So we're thankful that we engage on Dallas County Health Department to help out, that their community health workers can help manage the asthma risk predictive model and the high risk and very high risk patients that need to be seen. So so they're going to help us out with that. So you can see that just the different, having a different system would not necessarily translate in a similar way as at Parkland. So next slide, please. So one thing that we found out is those variable factors that were used to our data sets with our patient population did not translate very well for Los Barrios and with Foremost. And honestly, I can't tell you the exact details of what into this. It's PCCI that's really good with data analysis and statistics and all that kind of all that stuff that goes over my head. But if you focus on the precision on the Parkland model at Los Barrios in the middle and the Parkland model at Foremost on the right-hand side, you'll see that the precision is, in terms of the very high, the red number at the very bottom, the precision of the very high at risk for pediatric asthma was very low at 2.32% and 4.5% with using the Parkland model at Los Barrios and Foremost. The Parkland model for the very high risk, very high patients who are very high risk for pediatric asthma is 30%. So PCCI had to be able to use different variables and use different ways to be able to get a model that worked better at those systems. So next slide. Okay, so I can't speak, this is a very busy slide and I can't speak exactly to it very well, but basically what had to happen in the left-hand side are the variables for the Parkland model, and the right-hand side were more variables, and they had to use different weighting on the different variables on the right-hand side for Los Barrios, because for whatever reason, the Parkland model worked well for Parkland, but it did not work well for Los Barrios. So Los Barrios, PCCI had to find different variables and also different weightings to be able to have a risk predictive model that works well for their system. So next slide. So for the Los Barrios model at Los Barrios with a different kind of model, you can see that the precision of patients who have very high risk for pediatric asthma went up to 50%. So through that, we're using a different risk predictive model for Los Barrios, which works better for Los Barrios, even though it doesn't, the variables are different for Parkland. So as mentioned, I can't really speak into the nitty gritty of how PCCI did this. Yolanda Pengesky would be able, who was here last year, she'd be able to speak to it a lot more eloquently than I can. But that's just an example of how we're using metrics to be able to try to utilize a risk predictive model in a different healthcare setting. And I think that's my last slide. Yeah, that's my last slide. Okay.
Wonderful. I'd love to be able to go ahead with Savannah. I just want to make sure that if Dr. Termelo is going to need to go, do you have a few more? Okay. Okay, great. So I'll ask Savannah to go ahead and then we can have a time for a couple questions. Thank you so much. It's really exciting work.
Okay, hi everyone. Again, my name is Savannah Panagopoulos. I'm one of the community health analysts on the child health evaluation team at Cook Children's in the Center for Community Health. I'm super excited today to just share some of our asthma data findings from our 2024 Community Health Needs Assessment, which we recently just wrapped up this past month. So it is now finalized and we're excited to share some of our data findings with you. And I think you'll also find that the data I'm about to share is very complementary to other data and perspectives that you've also already heard today. So next slide, please. Okay, so just real quickly, I'll just share really briefly about our methodology so you kind of understand more about where this data comes from. We'll really focus on our asthma findings. I'll talk a little bit about a call to action, some steps that will probably really help inform our sessions later today. And then my favorite part, I'll share the data dashboard with you so that you can access this data when you need it anytime. Okay, so a little bit more about our coverage in our service area. So Cook Children's serves the 8 counties you see there on the screen. So we have Collin, Denton, Grayson, Hood, Johnson, Parker, Tarrant, and Wise. And so our community health needs assessment does focus particularly on these 8 counties. And so we're very fortunate to serve these 8 counties at Cook Children's. And we're really also thankful that our leadership puts emphasis on our community health needs assessment because this allows us to fulfill our promise, which is to improve the well-being of every child in care, but also in our communities. And so I just wanted to kind of provide you a snapshot of how large just these 8 counties alone in our North Texas region is. So across the 8 counties, we have an estimated 1.2 million children. And so just here's a little bit of breakdown per county. But really what this is meant to tell you is that not one entity can address all of these needs and provide all of this care. So it largely depends on collaboration, community partnerships, and working together, not within silos. So I'm excited to share what we could do with the data. Okay, next slide, please. So just real quickly, you're going to pretty much hear the data from our parent caregiver survey, and I'll talk a little bit more about what that entails on the next slide. But also you're going to see data that's labeled as under-resourced. And what this is our parent caregiver survey, but we had our partners over at MHMR Tarrant County conduct this survey face-to-face with families who are experiencing homelessness or have a caregiver who is undocumented. So these are families we wouldn't have been able to traditionally reach by mail, by phone, or by internet. So we also wanted to be able to collect their perspectives. And then I have to shout out our community health workers who conducted our family caregiver interviews. You'll see some quotes today from caregivers whose children were enrolled in our Healthy Homes program. And so this just helps provide that real story behind the data that we're also collecting. We also were able to interview some patient families that didn't speak Spanish nor English, so also able to collect more insight from different caregivers. And then, of course, we interview our community leaders and also provide a survey to them so we can hear from those who really understand their communities the best. And I know one of those leaders is here today, I think Cynthia Ortiz. We did interview her just particularly for Parker County because this allows us to really connect the dots and really understand the story. And then, of course, our secondary research. Okay, so our parent caregiver survey is 57 questions, and then a lot of these questions are based on questions from the National Survey for Children's Health. So this allows us to compare our results on a national level state of Texas level, and it asks a variety of questions. So we look at access to care, questions around health insurance, emotional mental health, healthy lifestyles, neighborhood, family caregiver relationships, and more. And so in total, we collected 6,877 samples for this 2024 CHNA. And then what we do is we weight that data so that our sample statistically represents that 1.2 million service area as a whole. So you're going to see some of our data where it says an estimated or an about, and that's just the weight of our sample so that it represents the larger group. And it is important to remember too that this data is descriptive findings. So this is the perspective from parents and caregivers. And I think it goes really well with clinical data that all of the healthcare systems see. And so just a reminder that this is what the perception and knowledge of the caregiver who answered was. And so, as y'all all know, asthma is one of the most common children's health conditions and also what we see across our service area. And so our rate of children with lifetime and current asthma is a little bit higher than both that state and national percentages. And so nearly 1 in 10 children, which is an estimated 104,000 in our 8-county service area, reported that their child currently has asthma. And something important to note is that we did find that our respondents who identified as Black, non-Hispanic, other multi-race, and Hispanic were disproportionately affected. So for our Black, non-Hispanic, the rate of asthma was 14% versus 9% from the larger group, 13% for other multi-race, and 11% for our Hispanic. And then our rates for under-resourced, which again were those families that have a caregiver who may be undocumented or they're experiencing homelessness, was at 10%. And this is a screenshot from our data dashboard, which I'll show you a little bit closer here at the end. But across that 8-county, that 9% or 104,000 that currently had, there was also 3% or 35,000 children who have been told their child has asthma, but they currently did not. And then 88% that indicated their child does not or never did have asthma. And so you can also see it's broken down by the 8 counties as well. And so uncontrolled asthma, as we know, does lead to increased emergency department visits and hospitalizations. And so of the children who currently have asthma across that 8-county service area, approximately 57% or about 60,000 had an episode of asthma or an attack in the past year. And 25%, which is almost 26,000 children, had been to the emergency room because of their asthma symptoms. And something important to note is that this percentage of children with asthma who had to visit the ER is approximately 3 times higher than what we reported in our 2021 CHNA findings. And so managing childhood asthma, as we all know, does involve a combination of medical treatments, environmental controls, and then education at the family and others in the child's life. And so caregivers of children with asthma reported that 8%, nearly 6,400 children did not receive all of the medication that was prescribed for them. And as I mentioned, our CHWs were able to conduct interviews with caregivers enrolled in our Healthy Homes program. And so I wanted to just read out a quote that a caregiver provided, and that's, "For the most part, my kids are healthy, but my youngest one has asthma, and sometimes the way he breathes scares me, and I stay up at night to watch him." So of the children who currently have asthma in the 8-county service area, here we are focusing a little bit more on that access to care piece, 17% indicated they did not have a personal doctor, and 23% did not receive all of the necessary medical care in the past 12 months. And when we asked this through the survey for all of respondents what the top 3 reasons were for not receiving necessary health care, the number one at 46% was that they could not afford the cost of care. Number 2 was problems getting appointments for their child when it was needed. And the third reason was insurance not covering some or all of the necessary care. And one of our caregivers also explained that the long wait times makes it difficult to get their child to the doctor. And because their medical issues are so intense, they would prefer to go to the ER than wait in between their appointments. Another one of our caregivers also mentioned, explained that one of the challenges is having others outside of their immediate family understand their child's condition and what it means to address that if the issue occurs outside of a caregiver who understands how to take care of their child. So one caregiver explained that they worry when they are not, their child is not in their presence, that if there were an emergency, someone would know what to do. And with their son's asthma, the doctor said they have to worry about his heart. And as mentioned, the importance of the individualized asthma action plans. In the 8-county service area, 19% of children and 35% of under-resourced children do not have their individualized asthma action plans. And so, of course, this is an important tool not only for the family, but for systems outside of the home. So their daycare providers, their schools, their after school programs, sports, that people in the child's life understands the very specific needs of this condition and what to do should an issue occur. And we also discovered that 24% of children who currently had asthma live with someone who uses cigarettes, cigars, or pipe tobacco, which could contribute to those asthma triggers. And in addition, children with asthma, of course, face academic challenges because asthma is one of the leading causes of children missing school. And nearly half of school-age children, which we defined as 6 to 17 years with asthma in our 8-county service area, and 43% of the under-resourced did miss at least one day of school, primarily due to asthma symptoms. And so asthma symptoms, attending doctor's appointments, and hospitalizations leads to multiple school absences. This then causes the child to fall behind, and that's where the struggle academically begins. And then, as also mentioned earlier today, this requires parents to take off work, to miss pay, potentially lose their employment if they have to take off. And also, children may find it difficult to avoid those triggers when they are at school. So it can lead to emotional and social well-being challenges as well. All right, next slide. So I just wanted to mention a little call to action too, based on the findings from our CHNA, what we learned from our community, what we learned from leaders, caregivers. And so I think most of you probably already know, but some of the top 3 ways that we can address or utilize these findings to inform our programs is first and foremost having personalized care and education. So having collaboration among families, their providers, and addressing a specific asthma action plan for families, as well as providing education, but then connecting them to the resources. So not just stopping by saying, hey, you need to do this, but hey, you need to do this, and also this is how you can get this resource.